for me to go into a little bit more deeply, but this is kind of the general flow, kind of where we've been as a state and locally, some of the dynamics that are going on, talk about some of the improvement methods that I've been able to use over the last several months with some of the teams and some of the projects and improvements I've been involved with. I'll share a couple of specific examples of things I've been involved with locally at our hospital, and then talk a little bit about lessons learned. So hopefully this will be something you enjoy. So this is me, Brian Hudson. I have a degree, Bachelor of Science and Master of Science in 1990 that I got from Purdue, so just across the river. I spent my first 15 years in manufacturing. Started in drafting, got into industrial engineering. For the last several years was basically a manufacturing engineer, business unit manager, and then got involved when kind of Lean and Six Sigma were relatively new to American manufacturing. So I spent the first several years, or last several years of manufacturing doing Lean and Six Sigma. I worked at two companies here in Lafayette, what used to be Fairfield, now Dana, and then TRW, which is now ZF, in those capacities. And that's where I really got that experience that then I was able to take to manufacturing in 2006. So I do work currently as a transformation coach, which means I work locally with the healthcare system here in Tippecanoe County, and I also work across the state with hospitals and other healthcare organizations that are part of our network around the state. I'm intentionally being a little bit vague about who I work for. I just want to say, you know, all of these views and all these things I'm talking about this evening are from my own experience. I don't know if there's any legal things. I don't want to get into anything like that. I just want to share, you know, my experiences and things I've been up to with you. So please don't take anything I say as medical advice or anything like that. But I'm part of a four-person team here locally, and we cover the hospital here in the county and then also two smaller hospitals that are nearby in our region. And then, like I said, I work with all the hospitals across the system. In this capacity, I get to work with any and every department in the hospital, which is really amazing. You know, today I was working on some radiology stuff, some stuff on delirium, some stuff with the inpatient nursing units. I was working on a corporate project. So really have the opportunity to work on everything, and it's really interesting. So I have some notes here, things I want to kind of trigger me as we go through this evening. So where we've been, again, I'm not a clinician. I looked this up on the CDC website earlier today. That's publicly available information. You can kind of see since the beginning of the year when things started picking up, this is nationally, number of new cases per day, so kind of up, and then it was down, and then we had a big spike. Then it was down in, you know, July timeframe, early August, and then it's been going back up again. And this is Indiana. We have fared, so this is just new cases, and this also comes from the CDC. So, you know, we had the big scare and things got better, and then it has continued to progress here over the last several months. This gives you a little bit of national information also, again, from CDC. So just kind of tells us where Indiana is relative to others in the U.S., number of cases per 100,000 people, and then, number of cases in the last 7 days. So our neighbors certainly have been affected on the eastern part of the United States. And so it's not going away. This little bit, again, information about Indiana, so number of cases by day. And then I grabbed this one. This was interesting, Tippecanoe County. So this is March, April, May, June, July, August, and really going up. So the people I work with, the people I talk to, people I work with every day say, you know, it's definitely going up. We're definitely seeing more of the effect of it. Every hospital has patients that are COVID positive, and here locally we have seen a number of cases and some of the higher numbers that we've seen through this whole thing. So just kind of where we have been over since the beginning of the year. I think I looked this up and it said 1,500 cases today, new cases, and then 36 in Tippecanoe County, which is a little bit down compared to the last couple of days. So this is where I want to kind of talk, given that background and given where we've been so far this year, talk about first some of the dynamics or some of the forces, things that are going on around us as it relates to, you know, the COVID pandemic. So as you have seen on the news, we see it on the news, we have a little bit better information, but lots of times new and emerging information. You know, at the beginning we didn't know. There was a lot of stuff we didn't know that we know now about how it's transmitted and the age of people and what it affects and how to treat it and a number of things like that. And we had never seen, in the modern era, we had never seen anything similar to this on the scale that we had seen it. And so early on, you know, communities completely shutting down. I know my wife works at Purdue. Her last day was March 17th, and she will not go back to Purdue yet this year. I had several weeks where I was working from home, and, you know, businesses shut down, restaurants shut down. It's kind of that early thing that we saw. You have heard a lot about testing and getting testing results, and that was difficult for, I would say, everybody, including the healthcare community. Early on, you know, not that we have them everywhere, but we have a much better supply of testing kits now. There are more different types of tests. Lots of the testing companies that make the equipment have developed more tests, which just opens the pipeline for the ability to get those. But early on, you know, that was one of the key things. We talked about it. We had daily calls at the beginning, and every single day we were talking about testing results, testing kits, testing supplies, where they are, do we need to move them around, getting more. I don't think that there ever was a time locally somebody wanted to get tested, that the supplies were not available, but we were just, you know, nervous about that. One of the other things I wanted to comment on the testing results thing, you know, kind of early on there was the rapid test that was developed, and the rapid test, the results come back within, you know, 5 to 10 minutes, and it's good for what it's good for, but the healthcare, the clinicians, I would say, kind of lost confidence in that test. I don't know what the exact number ended up being, but what early on in the conversations, the things that I heard was that it was about a 70% false negative for those rapid tests. So if somebody was early in their COVID timeline, it was not so good at picking up that they were positive. And if they were really, really sick, then it would have a better chance of picking that up. So think about that 30% grouping there that, and that was enough for the healthcare community to say, you know, we can't rely on that. So that still kept a lot of people, a lot of those tests going in the direction of the longer tests, the tests that we had to send into the central lab. And, you know, those got to be 5, 6, 7 days to get those results back. So that was certainly one of the dynamics in all of this. Another one of the dynamics, you know, for us in particular, and several other larger health systems in Indiana, since we hadn't dealt with things like this before, we didn't have, you know, the things already printed out. We didn't already have the information. We, you know, a lot of things about signage and other things. And so the guidance, we had a bit of a time where we're trying to figure out, is this something we can figure out locally, or do we have to wait to get the corporate guidance on this? So just being part of a large system has, you know, lots of pluses to it, but it did cause us to, you know, have to wait for some things, certainly not care-related things. Those were always taken care of, but some of the other kind of outlying things. I wasn't quite sure how to say this, but our governor, I appreciate all that he has done. He's done a tremendous job. There were a couple of times when he would say things in his daily briefing, and the healthcare community didn't have a heads up that he was going to say that and talk about it. And so one of the things was around procedures and elective procedures, and that, you know, they were going to be suggesting that that stuff was going to get halted and other things. And so there were times, you know, that press conference would happen like around 2 in the afternoon. You know, we would hear things, and then we would have to kind of figure out, okay, so how are we going to implement that? People are going to start asking, our employees are going to start asking. So that just created some additional work when those sorts of things would happen. The thing I wanted to say about drawing on our experience, so I said early on, you know, we had not really experienced anything similar to this. Some of the people that I worked with, I wasn't part of this back then, but the Ebola stuff that happened a couple of years ago. We had already figured a lot of stuff out. We had, you know, the documents and the flow charts and the procedures that had been developed back then. And so I guess where I'm going on this is a lot of those things we didn't need to. We didn't have to start from a blank piece of paper. You know, we went and we got a lot of that information, and certainly, you know, we have people that their full-time job is emergency response, and they eat, sleep, drink this stuff every day, and they know about, they're keeping their eye on reports, and, you know, they already had the stashes of PPE and all these other disaster drills that we do and all that stuff, and so they were very key in all of this, but we relied a lot on that stuff that had been developed in the past so that we didn't have to start from new and develop all of that. So that was very helpful. And then the last thing I wanted to mention as far as dynamics for our organization, it was stated very early on, you know, as restaurants and other businesses were closing and letting people go, our CEO said from that very early time, we are going to keep everybody whole. We are going to continue to pay everybody. And that was a huge commitment, huge financial commitment. But it, you know, really showed the organization's commitment to us employees. And so part of 2 main things kind of happened from that. One was people got redeployed to other areas. So we had some people that went around and, you know, might have been a physical therapist yesterday, but now they're going around wiping down, you know, doorknobs and handrails and, you know, mopping things and cleaning things and that sort of stuff. So redeploying people in some roles. One of the things I was part of, and this was a huge endeavor, was that we created very quickly about 100 computer-based testing modules about improvement-related stuff. You know, some team stuff. I didn't mention this earlier on, but I'm kind of a lean guy. So we had, you know, a lot of content that was sitting there, and we turned it into these computer-based training modules so that people could watch them from home during the 40 hours in the week that they were getting paid. They were getting credit for it. So that was huge as far as building confidence and helping people feel, you know, good about the organization that we are a part of. So many other dynamics going on, but I just wanted to highlight those couple there. You know, as I was looking back and thinking about some of the key things that happened for us over the last couple months. So a couple of examples of things that I personally was involved with. As I mentioned early on, you know, I was a manufacturing engineer for many years, production manager, very used to working with processes and developing new processes. And so, you know, as some of these things came up, you know, I would meet with a number of the people and flow chart it out and then go test it and work it out. So I mentioned earlier about the lab testing and get the results back. There were, I think, 3 main tests that we used, and so what I did was I developed a big flow chart to help people determine which one of those tests to use. Is it somebody that's, you know, got these symptoms? Is it somebody that's got a procedure coming up that you need results back quickly? You know, and some of the other things. And honestly, there for a while, I was updating that thing 2 and 3 times a week, and I'll touch on that a little bit later, but getting that information out. So I didn't have the technical content about what those lab tests were, but I was using my skills to go and meet with those people, have meetings, talk through the flow, capture the data, put it into that flow chart, and then send it out to everybody. So that's one of the roles that I was part of. Another thing that I got involved with was the drive-through testing. So perhaps some of you have gone through a drive-through test or had other COVID testing done. And so, you know, we just got a big map of the parking lot and said, you know, what makes sense as far as the flow goes. We don't want to back cars up to the busy street that's in front of our hospital, and, you know, how do we snake them through, and getting the signage and getting everything that was needed. There was a lot of guidance out there as far as the actual process of getting the swab and breaking the tip off and having somebody else pull the bag open and seal the bag and all that, those people that you saw on the news. But for us, helping to develop that process and then going to the Gemba and spending a lot of time there in the first several days, the first week we were doing this. And after, you know, many of the first cars, we would say, okay, how did that go? What went well? What didn't go well? What do we need to do differently? At the end of the day, doing a debrief, you know, what do we need to take care of for tomorrow? Do we need to change the traffic flow? Do we need to change the instructions and any and all that stuff? And so, again, I don't have the technical content on that, but I'm just a facilitator for those people that are doing the actual work. Reusable gowns, that was something I was involved in just within the last month. So as you may have heard or can imagine, all of this PPE got really expensive really quickly. We have, they're supposed to be throwaway gowns that we use for patients that are in isolation, so COVID suspect or other things that are going on. And so they're like single use. You go in and you do what you need to do with the patient, whatever that care is, and then when you leave the room, you tear it all off with your gloves and everything and throw it away. I don't know for sure what the original cost of those were. I want to say probably $1. When we got this team together, the team was formed because it was we were paying a lot of money. I think last count we were paying about $6.80 a piece. And so we had looked at reusable gowns before that we send back to the laundry company, and then they wash them and send them back. And we got bids on that, and it came out to about 47 cents a piece. So everybody was excited. Yes, absolutely, we need to do that. And so I worked with the head of environmental services and all the nursing department leadership to spell out what that process is going to be like. So one of the, I don't have this in the lessons learned, but one of the things I've learned that I have to be when I do this kind of work is I have to be very specific with people. You can't leave a lot of stuff up to interpretation. And so we said, okay, the big tote is going to be here that's got all the laundry ones in here. And then this person is going to bring them over here, and they're going to open the bag, and they're going to put them in here. So I developed that whole standardized work, just spelling all that stuff out. So that actually just went live this week. We had a lot of the single-use gowns, and we needed to burn through that inventory before we started the reusable gowns. I was not involved with this particular one, but with the N95 masks, there was some guidance that came out, and with some equipment that we have that does some sterilizing. We usually use it in the patient rooms after somebody's had some sort of a bug in there and they get discharged. We'll put this piece of equipment in there and turn it on for half an hour, and it kills all the remaining bugs after they've gone through and cleaned it very thoroughly. And so they found that this piece of equipment could also be used on the N95 masks. So my counterpart, Jeff, spent a lot of time developing that process, what it's going to look like, getting the room and getting some reflective material around the outside of the room and getting the racks and how are we going to collect them, and people can't write on the masks, so put them in the paper bags and all that. So that was an interesting thing. We've since stopped doing that because we have a better supply of N95 masks, and we could fire it up again at any time if we needed to. I was involved with a couple of projects at the visitor entrance. So we have 4 main entrances to the hospital, and so we needed to narrow that down really quickly because we needed to filter everybody in to where we had the screening process happening. And so a lot of the patients then were directed to the visitor entrance. So then we also had visitor restrictions that we put in place and helping them develop a process for making sure we understood, there can only be 1 person per day. That was a painful time that we were in, especially when we had some patients that were very sick. But that was the guidance. So how are we going to implement that process? And then reopening for elective procedures. So we have, surgery, cath lab, cardiac testing, interventional radiology, many other elective procedures that we do. And so I brought all of those leaders together and said, how are we going to do this and how are we going to do it consistently? And so what we ended up landing on is when patients arrive, they're going to be told, call a phone number, let us know that you're here. And then we'll either tell you to come on in or we'll take your phone number and then we'll call you once we're all set and ready for you. Because we just didn't want people to, collect in waiting rooms and collect in, the entrances and that kind of stuff. So that was interesting. It's kind of interesting looking back on this list and some of the things I was involved in being able to do. So I want to spend a little bit of time talking about improvement methods. I remember when I first started this job, like I said, I worked in manufacturing for about 15 years, and I got the phone call from a friend of mine that said, hey, would you be interested in coming to the hospital to work? And I said, I don't know anything about hospitals. I don't know anything about healthcare or processes. And she said, that's fine. We'll teach you all that part of it. We'll, show you what you need to know with that. We need help with improvement processes and methods. And at the time, it was Lean Six Sigma that we were talking about. We need help with that. And so I share that with you to say, I have very similar experience to a lot of you that I got in those 15 years that I was in manufacturing, working on improving processes and PPAPs and FMEAs and all that kind of stuff. So I wanted to share some of these things because these are skills that I developed in my time in manufacturing, and then I just continue to use them in this time and really the whole time I've been in manufacturing. So first thing I wanted to touch on there was about just working with teams, pulling together cross-functional teams to figure things out, solve a problem or develop a new process or get to the root cause of something, whatever that is. It's just like what you all do, assuming most of you are manufacturing related. It's just like what you do. I just do it with a different group of people, with physicians and nurses and techs and administrators, doing that kind of stuff. So that's one of the things I most enjoy, is being able to work with teams on that. Connecting with people with similar dynamics. I'll just kind of jump down to the next one here because they kind of go together. The idea of system thinking. One of the things I learned in my time in healthcare is that people that have a particular job, they know that job inside and out, and they take a tremendous amount of pride knowing that job very well, and they do it amazingly well. But many times they have no idea, what happens upstream from them and what happens downstream. They know that they get this thing. It might be a patient, it might be a blood specimen, it might be whatever, an x-ray, and they do their part of it, but they don't have knowledge or appreciation. So I feel like this is one of the things that I bring to it, because I've worked with so many projects, so many departments, that I bring some of that system thinking to it. And then I try and say, hey, let's, that thing came from this department over here. Let's go over there and talk to those people and see, why is that the way that it is. Particular example I have with connecting people with similar dynamics, probably about a month ago, and you can already appreciate this because I told you the other part of the story before. The HR department, we have a number of openings in the healthcare system, and so before all of this, they had done what they called Walk-in Wednesday, which is kind of an open time for anybody to come and talk about jobs and potential opportunities and that kind of stuff, and they stopped it in all the COVID stuff. And they wanted to restart Walk-in Wednesday because I feel like they really got a lot of great candidates and filled a number of positions doing that. So they're trying to figure out, we can't just have people come in and wander around and walk into HR and find the computer lab. We have to be much more careful. They won't let us do that. So kind of I went into that mode of, being very specific and scheduling appointments. And finally I said, I'm thinking of a similar thing that I've been working on with these outpatient procedure areas, where they have people wait out in their car, they call and say that I'm here for my scheduled time, and then we say either come in or we'll call you back in a minute and have you come in at the time for your scheduled appointment. And I hope I'm saying what I mean to say. They loved that idea. They had never thought about that, but I was able to bring it to them because, we had done that in this other area and had, this similar situation that we had done. So that idea of system thinking, it may not be the exact same problem, but you may be able to use similar ways of thinking about it and helping a team solve that. I found this quote this morning. I've been thinking about it and thinking about this idea, and I wanted to incorporate this now. There are many different ways to say this, but the idea that a good plan today is better than a perfect plan tomorrow, perfect one tomorrow, and that's credited to General George Patton. How I would say that a different way is that many years I was diagnosed with an extremely serious affliction, and some of you may know of this extremely serious affliction called analysis paralysis. And so I had a plant manager that cracked me over the skull a couple times to break me of this analysis paralysis that I had. And so, you know, certainly in no way do we intend to put anybody in harm's way, but we need to get something out there quickly. And we can tweak it tomorrow, and we can tweak it again next week when we learn more and we, you know, figure some other things out. So there are a number of people that, you know, want to continue to get every single possible scenario and make sure every I's dotted, every T's crossed, and everything is exactly perfect. But it's going to take a week or 2 weeks to get that done. And so for me, just to, you know, kind of push the teams, push people, we got to get it out there. We can't, you know, be waiting. This is the best information that we have right now. You know, again, not looking to compromise patient care or patient outcomes, but I just wanted to share that idea with you. And then the last one, I kind of touched on this a little bit, is, you know, just the continuous improvement, Plan, Do, Study, Act. You know, a lot of these projects, I talked about the lab testing thing. The other project I worked on in the visitor entrance was around patient flow as they come in. You know, we had some turnbuckles and, you know, ways that patients and family members went through the lobby. And it took us a couple different times to find what actually worked. And so, you know, me sending the message, it's okay. People want to work and have it be perfect that first time. And, you know, it's okay to work through it, and it's okay to reflect back. You know, I mentioned about the drive-through testing. What didn't go well with that? What can we do better next time? What do we need to revise, and what do we need to take care of so it's even better next time? So I just wanted to share a couple of those thoughts with you. Again, those are things that I learned when I was in manufacturing that served me very well. I think this is about my last slide, and a little quicker than I thought, but the last slide here, I want to talk a little bit about lessons learned and share, you know, some of these ideas with you. So learning about the latest treatment protocols, I would say that the world of medicine has been amazing at disseminating the latest ideas, the latest thinking, the latest research to the people that are providing care. I've talked to a couple of our hospitalists about this and said, you know, how do we do that? How do you know about what the latest thinking is and what you know, if something has changed and you need to be doing something different as far as treatment goes? And he said, we get all kinds of that information whenever anything new comes out. We know about it, and we talk about it, and we figure out, you know, what's going to take to implement this. So that really has been amazing, something that I have learned through all of this. This next thing I wanted to talk about, and maybe, you know, you can think about this, the idea of source of truth. So this doesn't necessarily pertain to the clinical care, it pertains to, you know, some of the other things, be it drive-through testing or other things like that. But making sure that decisions that you make are based on solid footing instead of just winging it or just some sort of a gut feel. You know, making sure that you can tie it back to that source of truth. I thought about an example that doesn't come to mind for me right now on that, but that way, you know, as things change and, you know, somebody wants to try something different, you know, really challenging them to say, you know, what is your source of truth on that? What is the footing that you have for that decision? What's the data that says that that's a better way of doing it? And always driving back to that. When it comes to people security, I talked early on about our CEO, you know, saying that they were going to keep people whole through all of this, and that has really been a key thing. You know, if people were nervous and you know, constantly having that apprehension about, you know, am I going to be here tomorrow? Am I going to have a job next week? Again, I know it's a tremendous investment to be able to do that, but it just has made all the difference to our organization and people knowing that they can just continue to do their work as they have done it all along. So I know that can't always be done. We're not always the people that are the decision maker on the ability to do that, but it's just been tremendously huge for us. Communicate, communicate, communicate. Probably figured this had to come up at some point. And so, you know, as part of this, as I made my notes, I was thinking it's extremely important and it can be difficult to communicate to an operation that is 24/7, 365. And people that work during the week don't necessarily work on the weekends. People that work on the days don't work on nights. You have people that will just come in for 1 or 2 shifts a week or every pay period. So how do we communicate all of that stuff to them, what the latest is and what the guidance is, so that, you know, if somebody's been off work for a week and they come in, you know, how do we get them up to speed to say, when you worked before, this was the guidance and what we were saying, and now these things have changed. So extremely, extremely important for us. And so this next one kind of ties into that. We really, before this, hadn't seen a strong need for this idea of revision or document control. And I know as I worked with a lot of my quality counterparts through my time in manufacturing, you know, document control is a huge thing. What's the latest revision? And making sure you destroy all the earlier versions of it and make sure everybody's got the latest thing. And so as I was telling you, you know, we're updating these documents. You know, today this is CDC's guidelines, and so we're publishing that. And then 2 days from now, some more new guidance comes out, and we need to revise that document. So we really had to get good and intentional about this idea of document control, because, you know, literally we're talking about people's lives. And if somebody does it, you know, the old way, they're not taking the latest guidance and instructions and procedures into consideration. So, you know, I know lots of people struggle with those old documents and copy of a copy of a copy of some form that was created 10 years ago, and just reiterated our need to be really good about this. And so this last bullet point, we'll talk about this a little bit more. I'm trying to think about how to talk about this part of it. This is going to be a little bit of a story. Several years ago, when I was the program chair for the ASQ section here in Lafayette, I was always on the scout for potential presenters, and I'm part of a couple different professional groups, and I'll be honest with you, there were a couple people that I recycled or reutilized from those presentations because they were such good presentations and I wanted to bring them to the ASQ section. And so one of them was a guy by the name of Jorge Sands, and I knew him from the Wabash Valley Lean Network. And Jorge, when he talked to the Lean Network, this has probably been 10 years ago now, maybe, Jorge talked about this tool called TRIZ, T-R-I-Z. And I'm sure some of you are familiar with TRIZ. And it just fascinated me because I'd heard of it. I didn't really know what it is. I'm not an expert. But the short version that I would share with you is back in, I want to say, the 1950s, there was a gentleman that worked in the patent office in Russia. And he would process the patent applications and award the patents. And you'd say, Brian, that's amazing. Why are we talking about Russia in 1950? But the idea behind this was that he started, instead of just like processing his paperwork through, he started like really reading it and studying each one of these things. And as he started doing this, he started realizing, you know, this idea that this person is claiming, you know, it is a unique thing in this particular setting, but I have seen this improvement before. It may be in something completely different, but this is not an original idea. You know, maybe somebody just now thought of it, or they saw it in this other application over here, and they said, you know, that coating that we put on this, you know, hammer over here, I'll bet that that would work on this cookware that my wife uses in the kitchen, or that I use in the kitchen. I do a lot of the cooking. And so then this new patent would come through that says, put this coating on this stuff that's used in the kitchen. So I hope I'm making sense with what I'm saying. But so what he was saying was, there really aren't new ideas. There are new adaptations of things that have already been done. So again, Brian, that's amazing. Why do you share that story with us? I share it with you to finish that sentence on there to say, this problem has already been solved. Before I came back to working in the hospitals about 5 years ago, I worked at Purdue for a couple of years. And I worked with hospitals through Purdue Healthcare Advisors, and this gave me the opportunity to work with about 40 different hospitals across the United States. And one of the things I saw over and over and over and over and over again, as I was working with these teams and working with these projects, these people had no concept of, and didn't take the time to say, you know, how have other people solved this same problem, even within their own health system. So I would go to, there's 4 main health systems in Indiana, 5 main health systems. I would go to one of them, to one of their small hospitals in southern Indiana, and I would see that they had figured out some problem. And then I would go to another one of their hospitals, and then they would be struggling with that exact same problem. I would say, hey, last week I was just down at, you know, this facility, and they've already figured this out. You don't have to solve this problem. And so where I'm going with this is, in healthcare, and I think a lot of other places, teams feel like they have to start from zero, and they think this problem can't exist anywhere else. It's unique to us. We have to start from zero and solve this problem. And so the reason I share this with you is that in a lot of this COVID stuff that's going on, and you saw it on the news just like I saw it, you know, how this hospital in Washington State had, you know, figured this thing out. And one of the things was where some family had made this thing so that the kids could hug grandma. It was a big piece of plexiglass, and somebody had some of those big long gloves that you use when you're, you know, veterinarian and with horses and cows and stuff, and they just duct taped them onto the plexiglass so the kids could hug grandma. And so the thought is, you know, that's just a couple of the examples. There isn't a good repository, and I would say those organizations don't even put stuff out there to say, hey, we had this problem and this is how we solved it. So I hope that makes sense. But think about that in your setting. It may be that you are the only place in the universe that does this particular thing. And so maybe nobody else has ever solved that problem before. But take some time to think about that. Ask people, where else in the corporation do we do this same thing? And what can we learn from them? Where else in manufacturing do they do this same thing? And what can we learn from them? So that you don't have to, expend 100% of the energy to solve that problem. Maybe you can take 50% of what they came up with, and then the last 50% is something that, just you and your team come up with to get it to the finish line. So that's a lot of information. But like I said, I wanted to, share some of my experiences and talk about things that I thought you would think is interesting. This is a picture I took a couple of weeks ago. They were tweeting these pictures up to hashtag Mask Up Hoosiers, and we were all asked to fill those out and take our pictures. So I know I said don't take any medical advice from me. Wear your mask, wash your hands, and get your flu shots. I got my flu shot this afternoon. So those are the important things. So that's all the information I had prepared. I'm open to taking any questions you have or anything else.
All right, Brian, thank you very much. That was fascinating. If anyone's got any comments or questions, feel free to end the chat or unmute if you want. We've got a few seconds for people to type something in or.
This is Bob Funk. I'm going to bring up an idea. Can anybody hear me?
Yeah.
Hey, Bob. One of the things that I do, being a reliability engineer, that I've found very similar to what you're talking about is I do what I call a what does Google see? And I do the same thing you're saying a lot of times where, in fact, I've used that for troubleshooting problems literally at my own company at times. Not the one I'm at now, but, it came down to you had some kind of a field problem on something, and then you would go out and you just start looking at the traffic out there. And it was funny because when you paid attention that way, you'd often see somebody say, don't they realize all they have to do is this? And I would throw that back at the team when I looked at it and it seemed practical, and it blew me away how often when you just looked at the traffic pattern of that repeated comment out there, how much it really was huge. Google seems like it's a megaphone for exactly what you're talking about. I mean, you got to watch what you look at, but it's huge for exactly that same thing. Just a thought.
Yeah, definitely. Definitely, we need to be more intentional about doing that because, like I said, that those problems have already been solved. So thanks for sharing that thought. Other questions?
I don't see anything else coming up right now, but I just want to comment. I think that was a great presentation. Having been in manufacturing my whole career, I find it very interesting to hear how these principles are applied in other areas. So I thought that was very interesting, especially what you learned how exactly that correlated with the kinds of things that are important in manufacturing.
Yeah, definitely.
Finding the truth, speaking with facts, and treating others with respect.
one piece of data is worth 1,000 expert opinions.
Oh man, yeah. Man. I like to tell my team, I'm a quality manager in manufacturing, I like to tell my team, get the data, get the facts, speak with facts. You don't have to fight the emotional fight that people are going to throw at you. You can just step back and say, these are the facts, and the emotion work itself out.
Well, I'm glad to have the time to speak with you this evening. I do want to call out, Greg and Scott and the others from the steering committee. Thank you for what you do. Having done that for many years, I know tremendous amount of time and personal energy that goes into getting these lined up. One of my other professional organizations has totally shut down. I've been doing these, video conferences, so I applaud you for keeping things going with this, so you can continue to provide programming and information for people, and it still takes time to put all that together. So thank you, Greg, and I don't know if Scott's listening in, and the others. I served on that committee several years with Bob Funk, who just commented, Sarah Louise and Roy and Dave Hudson and others, and it's a tremendous service that you do for the community.
You've always been a major part of that too, and we really thank you too.
Yeah, absolutely.
Absolutely, glad to do it.
Well, I don't see any other comments. Just for everyone listening, I've already gotten a few email requests, but if you'd like to proof of attendance, just send me an email. I put my email address there in the chat box. It's also on the newsletter that came out. I'll just take a screenshot of the participants here, so I can use that as a attendance roll and then send me a request. With that, I don't see any other comments, so I guess we'll close it here. Again, Brian, thank you very much. And wish everybody well, and thank you.
You're welcome.
Thank you. Have a good night.
Thank you.
Thanks again.
Thank you.
Yeah, absolutely, Bob. It'd be great to catch up with you someday when this all blows over.
Yeah, I understand that comment. Yeah, just FYI right now, I'm actually working for Carrier Corporation now, and what you're talking about actually hits home to me because we now have negative air machines.
Wow.
So that's something that I know we've got them in at Purdue, and we've got them in a lot of places, and I think in several hospitals too.
Okay.
So, anyway, yeah, keep up the good work. Thank you so much.
Yeah, absolutely.
Okay. Bye.
Bye. See ya.
Well, Brian, thank you so much.
Yeah.
That was great.
I'm glad it worked out, and
yeah, I'm thrilled it did too.
was nervous.
Yeah.
Whatever I'm going to present, there's enough good content there that people find it interesting.
Oh yeah. I saw Scott getting on once or twice. He warned me that he'd have to jump off now and then for work, and he texted me and said his microphone wasn't working.
Oh.
I wasn't able to speak out at all. But, all right. Well, thank you very much.
All right. Okay.
Take care.
All right. You too.
Bye.
Bye.